Welcome to another episode of Health Matters. I'm Ryan O'Connor. These are brought to you by Cipla. Now, for many people, especially those living in peri-urban and rural areas, access to quality, affordable primary healthcare services pose a significant challenge. Existing medical facilities are often overburdened and congested and may be difficult and costly to reach. Sha'p Left is a patient-centered, cost-aware, nurse-driven primary healthcare service that treats people closer to home in their communities. The Cipla Foundation provides infrastructure, systems and support to highly qualified Sha'p Left nurse practitioners to enable the delivery of accessible, quality and, more important, affordable care in a dignified setting. Overburdened state healthcare facilities are typically congested, resulting in extended wait times for patients seeking services. We know that this is true for patients who visit these clinics on a regular basis to collect their chronic medication, for example. Sha'p Left has established a network of pickup points to support the Department of Health's initiative to supply chronic medication to state patients outside of state health care facilities. This initiative aims to help decongest facilities and free up much-needed resources to treat sick patients. My guest this week is Dr. Harold Amaler.
That's
Doctor,
right.
So lovely to have you with us.
Thanks, Ryan.
Resident expert at Cipla and CSI advisor. Harold, thanks for joining us. Talk about Sha'p Left. Tell us about the state of primary health care as it stands now in South Africa.
Yeah, I think that we're all very aware of the challenges that our country faces around healthcare and a myriad of other things too. The NHR conversation is certainly focusing a lot of attention on healthcare, but as human beings, it's a daily need for many of us and our families and our loved ones. I think we're also aware of the degree of strain that the country is under. One of the things that is being highlighted through the NHR conversation and narrative is the two-tiered system that we have. So there's the private sector, which services 14-15% of the population, and there is the public health sector, which services the remainder, the 85%. And the differences between the two are stark.
Yeah.
The whole thing of NHI is to try and build a universal health coverage component. UHC, universal health coverage, is something that is internationally recognized as the goal to which we should all be aiming for.
Sure.
And the government has a mandate to get us there. So in order to get to universal health coverage, we've got to really look at what is happening between those two different worlds, private healthcare and public healthcare. Public health system is creaking big time, overburdened, under-budgeted, under-serviced, and probably not as well managed as it should be. So the impact of that on the vast majority of South Africans is that healthcare is a very difficult service for them to access. In the public health sector, there's a different range of challenges. I think that there are probably some degree, significant degree of over-servicing. It's very, very expensive. People have medical schemes which they think will cover them for all of their healthcare needs, and your smile just tells me you experience the same. You run out of funding halfway through the year, and then there's out-of-pocket expenses. And for the people who are fortunate enough to have medical cover, but on the lower end covers, they suddenly find themselves also in need of having to spend directly money on healthcare. So, it's a complicated terrain, and there's not one easy answer to give you. I think that people access there are pockets of excellence. There are true pockets of excellence in both sectors, but it's a tough world, and we try to find the solutions.
You'll know better than most about what's actually happening on the ground. And when we talk about hospitals in communities, we forget that people need to get to these hospitals in communities that are often in places unknown, and that in itself is a huge kind of expense and inconvenience. What is happening on the ground at within hospitals and clinics and communities?
Yeah, and it's important actually to differentiate between the two, because the vast majority of people access healthcare through the clinics, through the bottom of the pyramid primary healthcare service. And then as need arises, they would be referred into tertiary or secondary and tertiary level care, which is really where the hospitals are. If you take a slice through all of that, as we were alluding to in the first question, they're challenges.
Yeah.
You know, so the hospitals they're not enough hospitals. There are not enough hospitals at places that people need to access. The hospitals struggle with their budgets, with their management, with having sufficient staff, with having sufficient specialists. You know, if you go to a hospital, you're expecting something more than a generalist. So that's one of the real challenges that they have. At a primary healthcare level, yes, the clinics are probably well placed, and there are many clinics. We may have enough clinics, but they are so congested and so overburdened with need. You know, South Africa we face this challenge of what is called the quadruple burden of disease. Communicable diseases, so, you know, COVID is one that comes to mind immediately, something that causes an infection. HIV is a huge communicable disease, still places tremendous burden on service delivery in this country. So the first component of the quadruple burden of disease is communicable diseases. Then non-communicable diseases, high blood pressure, diabetes are the things that we know about. The third component is maternal and child health, huge thing. Our infant mortality rate is much higher than it needs to be. So it's another major focus. And then the fourth burden of disease is trauma and injuries, huge in this country as well. I mean, we all know the disastrous road accident stats that we have, and then also the violence that exists in the poorer communities. So the clinics are really at the forefront of having to deal with this quadruple burden of disease. There's just not enough skills. There's just not enough capacity to deal with it. Then you also mentioned another interesting point about how do poor people access these facilities. So if they have to take a day off work, or if they have to purchase transport to get there, then they get there and they sit in these queues 4, 6, 8 hours. People can sit waiting to be seen because of the volume of need that is in those facilities. So I can't sugarcoat it. It's tough, man. It's tough. And we're trying to find solutions for this. And the government, to their great credit, is also trying to find solutions to this.
Speaking of solutions, Sha'p Left.
Yes.
Tell us about Sha'p Left.
Yeah, you know, Sha'p Left is something that we've been developing over the last, I guess, 7, 8, 10 years, maybe. It's been going for as long as that. Really what we're trying to do is to try and find some solutions in that bottom of the pyramid need. So we're really not looking at any secondary, tertiary level care. We're looking at, in fact, we call it primary health care because it's a rung below GPs even. There are a couple of components to our Sha'p Left solution. And why Sha'p Left? I mean, the way that we got to Sha'p Left, one of my colleagues did some research on this and used a bunch of smart marketing kids in KZN, and they came up with this name, Sha'p Left. Why Sha'p Left? Because where's my healthcare? Just down the road, Sha'p Left, and you'll find it. Exactly.
It's clever.
Cool. And I don't know, it's caught on. So what is the Sha'p Left activity service? As I say, a couple of components. The first component that we got involved in is nurse-driven primary health care. Not enough doctors in our country to service the needs of the broad community. So can we look at nurses who are suitably qualified to provide a degree of that service? There's another organization called Unjani, upcountry. They've also do pretty much the same service as ours. And together, we're working very closely together. You know, one of the cool things here, Ryan, is that the space that we're playing in is not a competitive space. The need is so huge that it takes away that need for us to take market share from somebody else and get into a competition. The market is so enormous that unless we all combine our efforts, we're never going to get close to reaching what we need to do. And that's really cool because it's a very kind of Ubuntu philosophy and a tacit expression of that. So our nurses is one component. The other component is we partner with the Department of Health to deliver chronic medication for stable state patients with chronic diseases. The vast majority of those are HIV patients, but as we were talking about earlier in the non-communicable diseases, that quadruple burden of disease, a significant percentage of those people have high blood pressure or diabetes or what have you. And the whole thrust of that project, which goes by the wonderful acronym of CCMDD. I'm going to challenge you at the end of this to tell me what that stands for. Central Chronic Medication Dispensing and Distribution.
Wow.
We didn't come up with the acronym. It was foisted on us. That's the name of the service through the government. It doesn't roll off the tongue easily. No. They've changed now to double up meds. Double up in township vernacular means shortcut. So it's a cool name as well. Double up meds. It needs to get some penetration into people's consciousness. But that whole CCMDD double up meds program is really designed to say these are stable patients. They don't need to go to the clinic just to collect their medication. They don't need to go to the clinic and lengthen the queues and block up the access to service for people who are sick or need acute care.
Yes.
So the idea is that there's this term about decongesting the facilities, and it makes an enormous amount of sense. So in that program, we've got 51 units, which we operate in KwaZulu-Natal and in Gauteng, where people can come and collect their medication away from the clinic and collect it easily.
Brilliant.
They turn around their medication. They turn around maybe 2 minutes. It might be a convenient place for them on the way to work or wherever it is. They're coming to do their shopping, and off they go again, and they can continue to take their medication.
Brilliant.
So those are the two main existing components.
Okay.
What we're trying to do as a further evolution of all of this is to blend those two pieces together, so that instead of you, after you've collected your medication, at some point in the annual cycle of getting your medication, you need to go back to the clinic for another checkup and for your prescription to be renewed. Can we take that service again out of those facilities and make it even easier for those patients to not only collect their medication, but get that required clinical service? And if they're sick, send them back into the facility. If they're not sick, let's just look after that group. In this new development, we call it a HAWK, another acronym. My world is littered with difficult acronyms. HAWK is a health and wellness center, so HAWK with a C. And we're really trying to get that HAWK to get air under its wings and to take off. It could be a real game changer.
Absolutely. If we look at the last year alone, some of the differences that Sha'p Left has made to these communities.
Yeah, I think we're making a small dent. The need is just so enormous. But it's the consuming an elephant story. And I do think we've taken a couple of good bites. And we've chewed hard on some of them. We've cracked the teeth a good few times on the bones and the difficult bits. But we undoubtedly we are making a difference. Are we making a big enough difference? Not yet. Projects like this need to scale massively.
Absolutely.
And scale, again, is not a parochial thing. It's not about us being so big that we are solving this problem. We could never be that big. If we get these formulas right, and they can be replicated easily, and there are copycats that come on board as well, maybe we'll get to this dream of universal health coverage, which is so fundamentally important, not just on a personal, individual level, but on a community and countrywide level, continent-wide level.
Global level.
Global level. No, absolutely.
What's next for Sha'p Left?
So, I've just spoken a little bit about this HAWK. That's certainly a model and a dream that we're aspiring to. We need to fly that into that 85% of the population that is being serviced by the state currently. So a lot of work to land that properly and engage with government. In the same breath, we need to look at amplifying the nurses program, partnering with others, working in a collegiate way with others like Unjani to grow that out. And then the CCMDD program also, we would like to really grow that out more and make that more stable and sustainable.
Collecting chronic medication, distribution and delivery.
It's not bad. I mean, there was a little bit in between, but you got the words.
Is it right? Collecting chronic medication.
You're not collecting central.
Central.
Yeah.
Central chronic medication dispensing and distribution.
There you go.
Wow. Can't believe that.
Not bad.
Listen, people are watching. They may be in that category of nurses or healthcare professionals, and maybe just a member of the general public. How do they get involved in this initiative?
Yeah. Look, I think general public, please support it.
Yes,
if there is an opportunity, if you do, if you are on chronic medication, ask your nurse, your doctor, whether you can enroll in the Double Up Meds CCMDD program.
Nice.
Definitely probably the biggest win we can have. We do have a website for our foundation. And if you want to participate in any way, in kind, in contributions, in inquiring about whether or not there are roles for you in this, please access that. And then if there are nurses that are interested in joining this, again, if you just follow that link on the Cipla Foundation link, you will find us.
Nice.
And we will engage with you, and perhaps there's some magic that we can make together.
Absolutely brilliant. Doc, thanks for your time today. Thanks for enlightening us as to Sha'p Left. And it's just the great work that you are doing. As you said, you take the elephant out bite by bite by bite, but somebody has to do that. Somebody has to look at the elephant and go, where do we begin? And let's begin. As opposed to standing back and being so scared of the elephant that we don't know where to begin. Someone's got to take that bite first and be the first to take a bite. So Sha'p Left, a huge thanks to your involvement in giving back and making a difference.
My pleasure.
Thank you for being on this podcast.
Let's do this together.
Ladies and gents, proudly brought to you by Cipla. Remember to like, subscribe, and join us next week for another great episode of Health Matters.